Hello and welcome to this educational activity entitled Expert Video Viewpoints on Castration-Resistant Prostate Cancer, Care Across the Continuum. My name is Emmanuel Antonarakis. I'm an assistant professor of oncology at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins, and I'm joined today by Dr. Leonard Gomella, Chairman, Department of Urology, Associate Director of Clinical Affairs at the Jefferson Kimmel Cancer Center at Thomas Jefferson University, and Dr. A. Oliver Sartor, Laborde Endowed Professor of Cancer Research, Tulane University School of Medicine. We would like to begin this presentation with Section 1, entitled Identification and Initial Treatment of Patients with CRPC or Castration-Resistant Prostate Cancer. We would first like to discuss how we identify our patients and how we define them with castration-resistant prostate cancer. And in doing so, I think it is helpful to look at this diagram of the prostate cancer clinical states, which is a spectrum of disease states starting from localized disease on the left, going all the way to the most advanced and chemotherapy refractory disease on the right. What we can see here is about 200,000 men or so are diagnosed with prostate cancer in the United States every year, and ultimately about 30,000 die of this disease. Depending on when they begin treatment with hormone therapy, either before or after metastases, most patients with recurrence will eventually develop a state of castration resistance. I would first like to start by asking Dr. Gomella how he defines a patient with castration-resistant prostate cancer in the non-metastatic setting.
Well, today the definition of castrate-resistant prostate cancer really implies two things. The first is a testosterone level less than 50 nanograms. The second thing is a rising PSA. That's the current definition that we use to define this condition.
And Dr. Sartor, if you had this patient in your clinic without metastases but castration-resistant disease with a rising PSA, how would you think about managing him?
What I typically do is some secondary hormone manipulations, perhaps even consider a clinical trial. But what I'll say is that if you look at the FDA, there's nothing actually approved in this space today.
What if a patient develops early signs of metastatic disease and yet they have no symptoms at this time point? How would you think about this patient and what kind of treatment options do we have for this? And I'd like to start with Dr. Sartor again for this one.
Well, you know, it's interesting. So we talked a little bit about FDA approval, but when we look at FDA approvals, now we do have something approved in the space, and that's sipuleucil-t. You can also use secondary hormones, and actually I use secondary hormones and sipuleucil-t together in my own practice. And then, of course, depending on the patient, you might actually consider chemotherapy because that's a viable option as well.
So just on that point of sipuleucil-t, I'm glad you brought it up. I think this will be a good time to just introduce that topic and talk about what it is and sort of how it works. Can you give us an insight on that, Dr. Sartor?
Sure. Well, it's an autologous immunotherapy, and it's quite interesting in the sense that you take the patient's own cells and then you give them an ex vivo vaccination and then give the cells back to the patient. Do it 3 times, and it turns out, and we'll see this later in the clinical trials, that there's a prolongation in survival when you do that relatively simple manipulation.
So Dr. Gomella, using this cartoon, could you please explain the immunological mechanism of action of this agent?
Well, it's believed that the activation of the dendritic cells ex vivo that Dr. Sartor spoke about causes the cells from the individual patient to recognize prostate cells. They're trained to recognize prostatic acid phosphatase, which is expressed on virtually all prostate cancer cells. When they're reinfused into the patient, these dendritic cells go and actually identify these specific prostate cells and begin the anti-tumor effect and T-cell activation.
Thank you very much. And now I'll ask Dr. Sartor to actually talk about the trial design of the Phase 3 IMPACT study, which tested this immunotherapy agent.
Well, it was interesting. This trial was based on some earlier randomized trials which showed a survival benefit, but they were really too small to be able to be definitive in their conclusions. So the company designed, under FDA guidance, a large 500-plus patient Phase 3 trial really to look at overall survival. And the trial design was a randomization between sipuleucil-t, or placebo, and there actually was the opportunity to cross over to a frozen sipuleucil-t in the process after progression. So this was the definitive trial that subsequently led to the FDA approval.
Thanks very much, and I think I will touch upon later about the crossover, what that actually meant in a bit more detail. But just for now, I'd like to ask Dr. Gomella to talk about the overall survival results from this study.
Well, the overall survival results really showed about a little bit more than a 4-month survival advantage. And this is really pretty significant because before sipuleucil-t, we were talking about 2 to 2.5 month survival advantages using docetaxel trials. So this is a pretty significant forward step in our management of patients with this condition.
One of the questions I always have with these new agents is what's their toxicity? So I'd like to ask Dr. Sartor to just highlight some of the common toxicity side effects that we see with this agent.
Well, you know, it's interesting. It's almost a flu-like syndrome shortly after the administration, so you can get chills, fever, maybe a little back pain, headache, and it's pretty transient, actually. So after you infuse the cells, this may happen over a period of, 24, maybe even as much as 72 hours, but then it goes away. And the good news is, in terms of serious side effects, they really are very minimal.
I'd like to ask Dr. Gomella, you presented at the 2011 annual ASCO meeting some very interesting data about what happened to those patients who progressed and who were then treated at the physician's discretion with the crossover arm. Can you talk about that?
Well, this is very interesting. When you looked at the trial, it was designed to allow patients who were treated on the placebo arm to actually receive the frozen version of their cells. And when you actually went back and you looked at the study data, it actually suggests that the so-called placebo arm lived a lot longer than you might otherwise expect. When you took those patients out who did not receive the frozen product, their survival was only 9 months. The survival of the patients who received the frozen product approached that of those patients that received the original treatment. So there's a suggestion that perhaps the frozen product may have actually made the survival difference not look as pronounced.
And now we'd like to shift and talk about what happens to patients who have metastatic castration-resistant disease who do eventually go on to develop symptoms such as bone pain. And I think this is a very interesting category of patients. And of course we have docetaxel, which is approved in this setting. Before docetaxel, really, we only had a couple of chemotherapy agents that we commonly use. One of them was mitoxantrone. Interestingly, that was an FDA-approved drug, but it was approved based on palliation of pain and not because of an overall survival benefit. And I think for many years before the 2000s, early 2000s, that was all we were doing in terms of chemotherapy. Then in 2004, there were 2 new studies with a new chemotherapy agent called docetaxel. Could I ask Dr. Gomella to describe those 2 trials?
This was really a big breakthrough in prostate cancer because this is the first time in 2004 that docetaxel was approved specifically for the treatment of advanced prostate cancer. And this was based on both the SWOG 9916 study and the TAX327 study that basically showed about a 2 to 2.5 month survival advantage with the use of these drugs.
I'd just like to get some more detail and ask Dr. Sartor to actually talk about the trial design of the 2 pivotal docetaxel studies.
Well, there's 2 different trials. One was a cooperative group trial done through SWOG, Dan Petrolak being the PI, and it actually included estramustine in addition to docetaxel as compared to mitoxantrone. The other trial was an industry-sponsored trial called TAX327, and that did not utilize a estramustine, but instead used a prednisone. And prednisone was in both arms and utilizing the mitoxantrone and docetaxel. And Ian Tannick and Mary Leisenberger were the PIs in that particular trial. So the trial design both used mitoxantrone as the control group because that was the FDA-approved standard, but the actual docetaxel arms varied a little bit.
Dr. Gomella, can we just review the overall survival results from the 2 studies?
When you really look at the overall survival results, they were about 2 months, perhaps a little bit more, both for the TAX327 and the SWOG 9916 trial. So again, while the difference in survival of a little bit more than 2 months was not that impressive, this was the first time where we had an agent that actually did extend survival of men with advanced prostate cancer.
Right, and I think that's very important. And since the FDA approval of docetaxel, I've heard Dr. Sartor mentioning this drug is a pivot point in terms of design of subsequent clinical trials. Can you talk to us about what that means and sort of other studies that have been designed with docetaxel adding new drugs?
Sure. Well, once you have a standard of care, and when docetaxel was shown to prolong survival, I think the field as a whole adopted docetaxel as standard of care. Then you had to sort of define your space as either, okay, we're going to go before docetaxel, we're going to go after docetaxel, or we're going to go with docetaxel. And of course, many companies saw this kind of 2 to 3 month prolongation survival, and they thought, well, gosh, maybe we can add our drug and do better. So there have been a whole series of trials that have actually used docetaxel plus another drug in a controlled fashion.
I would just like to summarize the current NCCN guidelines for the treatment of castration-resistant prostate cancer, beginning with those patients, as we mentioned earlier, that have no evidence of metastases and yet meet the criteria for castration resistance. And I think we've covered a lot of these therapies. Obviously, in these patients, clinical trials are the preferred therapeutic choice because there's no FDA standard, so to speak, in those patients. Again, secondary hormonal manipulations are important, as well as this anti-androgen withdrawal syndrome, where some patients, 30–40%, can have a PSA decline after stopping the anti-androgen. In addition, we know that there's other adrenal gland androgen suppressing therapies such as ketoconazole, which has been used for a long time in these patients, as well as some other estrogenic compounds, as well as steroids. Moving on to consider the patients with positive metastases and castration resistance. I think in the asymptomatic patient, sipuleucil-t has a Category 1 recommendation for treatment of these patients. And then all the other secondary hormonal manipulations, ketoconazole, antiandrogens, estrogens are also reasonable options in these patients. Although I would tend to use sipuleucil-t now that we have a level 1 evidence for that in the appropriate patient. And finally, what about the patient that has metastatic castration-resistant disease with early evidence of symptoms, bone pain, other symptoms? I think for this patient, we have very good evidence for docetaxel. Other chemotherapies like mitoxantrone were used in the past. I think they're going to be falling out of favor a little bit now. There's some new drugs, abiraterone, we'll talk about later. Hasn't had an FDA label in this setting, but it has been used, as well as some other palliative maneuvers, such as radiation therapy to bone and radiopharmaceuticals, which can provide some really good quality of life, palliative benefit as well. And so I'd just like to close this session by asking each of you, sort of what are the criteria that you choose to decide when a patient should start on chemotherapy? I'll begin with Dr. Sartor.
Well, it's an interesting question, and in part it depends on the other alternatives in terms of how the patient's been treated previously and what they have not seen. So if you have a patient with metastatic castration-resistant prostate cancer, they clearly fit the FDA-approved label for docetaxel. But if they may have never seen a secondary hormone, potentially they're referred in from a urologist and maybe they weren't really followed very closely, for instance, that it's possible I might even use a secondary hormone in that situation. On the other hand, for patients who are rapidly progressive, particularly those who are symptomatic, I think chemotherapy is the standard of care. And those are the circumstances that I move to chemotherapy pretty rapidly.
Dr. Gomella, anything you want to add? And when would you refer a patient for chemotherapy, or when would you give that yourself?
Well, I think one of the issues that we're dealing with today is extending the survival of our patients and the quality of life of our patients. And I think that earlier referral for these patients, particularly when they are in the symptomatic state, to medical oncology is very critical in getting them on a regimen that may give them a survival and a palliative care advantage.
Thanks very much. And just before concluding section 1, I have just some key takeaway messages that I'd like to leave with the audience. First of all, we currently don't have any standard of care for patients with non-metastatic castration-resistant prostate cancer, but several reasonable options include secondary hormonal manipulations, including ketoconazole and other secondary hormones. Sipuleucil-t is really the first agent, immunotherapy agent approved for any disease, not just prostate cancer. It happened to be in prostate. And it's indicated for patients with minimally symptomatic or asymptomatic metastatic castration-resistant disease. And finally, docetaxel chemotherapy should probably be reserved for those patients that have symptomatic and metastatic castration-resistant prostate cancer. This concludes section 1.